We're getting an urge to push from the parking lot.
Okay, let's go to room 1, and Alice, let's turn on the infant warmer. The triage nurse huffs behind the mother-to-be in the wheelchair, pushing her as fast as she can into the ED. What now?
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. This baby is getting delivered by you now. Today we'll go over the 8th edition of the Neonatal Resuscitation program from the American Academy of Pediatrics. First, we'll go over the normal order of operations and review the initial steps and triggers for resuscitation, a broad overview. Then we'll go through each step so we have a good foundation and understanding that will definitely come in handy when things just don't work out as scheduled. Any time you have just before the actual birth is precious. Do a quick team briefing. Check your equipment, bag, suction, oxygen. Turn on that infant warmer. And now the baby's here. Within the first minute, you ask yourself, is this a term gestation? Does the baby have good tone? Is he breathing or crying? If yes, put that little one skin to skin to mama. Make sure she has him held tight, and at about 30 to 60 seconds, you can routinely clamp the umbilical cord. All right, what if the baby isn't making noise? Hasn't taken a breath yet? Maybe he's floppy. No problem. In the first minute of life, you have time to warm, dry, and stimulate. That is all the vast majority of babies need. Warm, dry, stimulate, suction if needed. At this point, you're clamping the cord in 2 places. You'll cut the cord and you'll put the baby onto the warmer. And what? Warm, dry, and stimulate, suction the nose and mouth if needed. At this point, life can take us into one of 3 possibilities. 1, baby just needs a little more time. He cries, he pinks up, all is well, back to mama's chest. Or 2, you now see continued labored breathing or persistent cyanosis. Maybe the baby head to toe just looks a little too purple. The child just needs some more support. No problem. Position the airway, do some good, super professional suctioning. Put on that pulse ox, apply oxygen by blow-by if needed, and think about maybe some nasal CPAP. Or scenario 3, if in the first minute of life, after warming, drying, stimulating, suctioning is needed, you still have apnea or gasping, or after a minute, the heart rate is still less than 100 beats per minute, it's time to give positive pressure ventilation by bag valve mask. The baby is not breathing regularly. His heart rate is now 90. You apply the small mask on the bridge of the nose to the cleft of the chin, position that airway, get a good seal. Be sure not to occlude the soft tissues under the jaw with your big sausage fingers. And squeeze, release, looking just for chest rise. Carefully not overinflating the baby's lungs. Squeeze, release. That's the tempo for newborns. Squeeze, release. 40 to 60 breaths per minute. The heart rate is now 120. Hallelujah. The child is crying. You did it. Make sure you do a great head-to-toe assessment. Make sure that child is doing well. Otherwise, you intervened when you needed to. And now you just got to make sure nothing bad is happening. Do a great head-to-toe exam. And if all is well, get him back to mama. Except life is not good right now. It didn't work, did it? Oh, why, baby, why? You have done the things. You've warmed, you've dried, you stimulated, you suctioned as needed. The baby was still apneic. You gave positive pressure ventilation. His heart rate is still 80. All right, time to get to troubleshooting. Is my mask seal okay? I repositioned, I suctioned, I opened the mouth. I even did some troubleshooting with the pressure delivered through the bag. I need that heart rate to improve. It's still 80. Nothing so far has helped. The next step, ensure adequate ventilation and oxygenation by placing a laryngeal mask airway or an endotracheal tube. RNs are trained in placing LMAs during NRP, the Neonatal Resuscitation Program. There is some literature to support it as well, so don't let that situation hold you back from doing the right thing. Okay, you've decided to intubate. You're successful. The child stabilizes. The heart rate is 140. Excellent work. Now do that good head-to-toe assessment and find out what's going on with this child. Update the family. Except that didn't work either, did it? Warm, dry, stimulate, suction as needed. You reposition, suction some more, try blow-by, try them on positive pressure ventilation, then you intubated, but his heart rate dropped below 60. What do we do when a sick child's heart rate drops below 60 despite adequate oxygenation and ventilation? Start chest compressions. How? Best approach here is the 2-thumb encircling technique. You encircle the infant's chest with both hands, you spread your fingers around the thorax, and place your thumbs together over the lower third of the sternum. 100 to 120 compressions per minute. 1 and 2 and 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 1 and 2. You have an advanced airway in. You're oxygenating and ventilating as best you can. You're performing compressions because the circulation is inadequate. Less than 60 beats per minute is not enough to meet the metabolic demands of a newborn. What next? Hand over CPR to someone else and get IV access. Now, you need some kind of access, of course. IV would be perfect, but let's be honest, that's probably not going to happen right now. IO works, so go with it. You can also quickly get a quick resuscitative umbilical vein catheter in. You can use a kit that you may have already pre-packaged, or you can grab a small French feeding tube, a 5 French for a full-term baby, insert it into the mouth of Mickey Mouse. Remember, the paired umbilical arteries are small and muscular. The large, floppy, singular umbilical vein is what you're looking for. Advance just until you get blood return, about 5 centimeters. We're there. It's time for epinephrine. IV or IO is the way to go in most cases. For NRP, it's 0.02 milligrams per kilogram. If you have no IV access, you can administer epinephrine through the ET tube, and it's quite a bit more given the bioavailability of this route, so the endotracheal tube dose epinephrine is 0.1 mg per kg, a higher dose because it's an inefficient route of delivery. Keep going. Think, why is this baby not responding to these aggressive interventions? What am I missing? Think pneumothorax from birth trauma or congenital issues, or maybe even your positive pressure ventilation. Think hypovolemia. Give a 10 ml per kilo bolus of NS. Keep going, trying to figure out what you can reverse. If, after 20 minutes of interventions, you have no pulse, then it's time to stop. Births are usually a happy, easy event with just common sense logic and normal supportive care. Neonatal resuscitations can get very upsetting very fast if you don't have a framework. Now you have that. Let's go through each step again, fleshing out a bit more and doing some troubleshooting. First, ideally, you have time to ask the 4 big questions. What's the gestational age? Is the amniotic fluid clear? Are there any additional risk factors? What's the umbilical cord management plan? The NRP is set up for an expected birth. Typically, there's time to prepare. If you're in the ED, mama just didn't make it upstairs, and that's okay. First, what's the gestational age? I'll first ask when the baby is due and just do some quick math for a general idea of very premature, or term. Is the amniotic fluid clear? We're looking for meconium staining and possibly preparing for respiratory distress after birth. Are there additional risk factors? These include multiple gestations, lack of prenatal care, low birth weight, preterm labor, preeclampsia, prolonged rupture of membranes, abruptio placentae, prolonged labor, and more. Basically, find out what you can, what's feasible to know right now, and knowing that in the ED the mother will be in pain and distressed, and you may not get more than just the very basics. What is the umbilical cord management plan? This has to do with the timing of cord clamping. In the past, we were taught to clamp as soon as possible, mostly so that we can then tend to the child. The new prevailing approach is now what's called delayed cord clamping, also called deferred cord clamping. This just means that we wait 60 seconds before we clamp the cord. The benefits to this approach is that the placenta will still pump some blood to the child while his cardiovascular system is transitioning from placental to pulmonary circulation. Delayed cord clamping supports better oxygenation during birth, better blood pressure, and better hemoglobin. It's especially helpful in preterm infants to decrease the risk of intraventricular hemorrhage. In fact, in preterm infants, delayed cord clamping can be extended to 2 minutes. There aren't many contraindications to waiting 1 to 2 minutes to clamp the cord. If the infant needs resuscitation, then you just have to clamp the cord as a practicality to be able to resuscitate the infant. If you happen to know that there is some twin-to-twin in utero transfusion or risk for polycythemia or some other odd random contraindication, sure, don't do it. But for the vast majority of infants who do not require intensive resuscitation, regardless of gestational age, wait 1 to 2 minutes to clamp. What does this mean practically? The baby's head is delivered, you support it, you deliver the rest of the infant. Warm, dry, stimulate, the baby cries, he goes to mama's chest for that ever-important neurohormonal regulating skin-to-skin contact. While mama is taking it all in, and you're drying the baby on her chest, and by that time, all of it's over, and you've gotten your instruments, time is about up, you can clamp in 2 places near the umbilicus and cut the cord at any point. Hopefully you have time for these 4 questions. Otherwise, just wing it. All right, baby's here. Term, tone, crying. Preterm babies will decompensate quickly, whether that's due to their incompletely developed lungs or their lack of adipose and risk for hypothermia. Remember the deadly triad in trauma. And yes, birth is, in a way, a trauma we all go through. Acidosis, hypothermia, and coagulopathy are the deadly triad. Acidosis from poor oxygenation, hypothermia from exposure, and coagulopathy, the yin and yang of bleeding and clotting, is not as finely tuned the more premature we are. This is partially why it's so important to know what size child to expect, aside from the airway and IV access equipment issues. Tone. A full-term, healthy neonate has a normal, flexed posture. He or she is brought into the world with both fists up, ready to fight. That's what we want to see, a lovely little fighter. If we see a droopy purple flower, we need to get to work. Crying. That's self-explanatory. A crying baby is a vigorous baby. When the baby takes his first breath, air replaces the fluid in his newborn lungs. Oxygen diffuses into the blood vessels surrounding the alveoli. This sparks a relaxation of the pulmonary circuit, and pulmonary resistance falls, allowing blood to flow into those lungs. For some babies, it takes a moment. Remember, we have that first minute to warm, dry, and stimulate. We want the baby to cry and start this beautiful process of his first breath. Now remember, we are using our own 2 eyes, ears, and fingers to figure out the newly born baby's clinical status. We see the tone, we hear the cry, we feel the pulse at the brachial artery or at the pulse at the umbilical stump. We don't use pulse oximetry to drive management, at least initially. Oh, ears perked up now? How long does it take for a healthy baby's SpO2 to reach 85, 90, 95%? 1 breath? 2 breaths? Try 400 breaths. It takes a full 10 minutes for the SpO2 to get anywhere near normal. So, at 1 minute, a healthy, screaming, pink little lover and a fighter has a normal SpO2 of 60 to 65%. This has a lot to do with changes in central and peripheral circulation, so don't expect a normal SpO2 until the child has transitioned from placental to pulmonary circulations. At 2 minutes, 65 to 70%. 3 minutes, 70 to 75%. 5 minutes, 80 to 85%. And finally, a normal pre-ductal SpO2 at 10 minutes is 85 to 95%. Totally normal. Use your eyes, ears, and fingers, and at this point, of course, the cardiac monitor too. That heart rate sometimes can be tricky to gauge with so much going on. So how do we remember this? Well, in NRP, we have that golden minute, right? We have that 1 minute to warm, dry, stimulate. 1 minute is 60 seconds, and so should be your SpO2. At 1 minute, 60%. 60 seconds, 60%. For every minute after that, add 5%. Show me your wristwatch. 60 seconds, show me your hand. 5 fingers. At birth, you are 60% SpO2, and you go up every minute by how many percentage points? 5 percentage points. Start at 60, go up 5% each minute to a normal of 85 to 95% at 10 minutes. Warm and maintain normal temperature, position the airway if needed, dry, stimulate, and suction if needed. You have 1 minute to decide if this kid is going to fly. You know it when you see it. Usually with minimal to brief stimulation, a baby is going to breathe. When you feel like it's an eternity and you are warming, drying, and stimulating and you are getting nowhere, you should ask yourself, is this baby apneic? If you are doing anything other than the routine, you should have that child in the baby warmer, place the cardiac monitor on there, and get ready to deliver positive pressure ventilation. If she is apneic or gasping for air, or if her heart rate dips below 100 beats per minute anytime, do not hesitate to start delivering rescue breaths. This is done ideally with a self-inflating anesthesia bag, which is gentle on the delicate alveoli. In fact, you set the peak pressures before you use it and deliver a breath just until chest rise. Alternatively, you can use the self-inflating bags that we use more often in the ED. When you're at the stage of delivering positive pressure ventilation, you should expect the heart rate to rise within about 15 to 20 seconds. If that's not happening, go through these steps. Do I have a good seal on the mask? Do I need to reposition the airway? Should I suction the nose and mouth? Should I open the mouth? Should I increase the pressure delivered in my rescue breaths? And finally, do I just need to place an advanced airway? Do I need to ask Mr. SOPA? That's the NRP's mnemonic for troubleshooting positive pressure ventilation, and really it works for anybody. So M is mask, R is reposition, S suction, O open the mouth, P increase pressure delivered, A advanced airway. Initial settings on the flow bag would be 10 liters of oxygen per minute, 21% oxygen, PEEP of 5 centimeters of water, peak inspiratory pressure of 20 to 25 centimeters of water, and ventilate at 40 to 60 breaths per minute, or squeeze, release, squeeze, release. If you need to adjust those settings because the baby's heart rate is not responding, then by all means do it. You can increase the peak airway pressure by 5 centimeter of water increments until you get to a max of 40 centimeters of water. If you still see the heart rate below 100 after positive pressure and ventilation, and Mr. SOPA did not do much help for you, it's been a minute. It's time to get an advanced airway in. An LMA is your friend. Endotracheal intubation is just fine, but remember, there is nothing magical about the tube. It's the end result, oxygenation, ventilation, that is the most important. If you intubate, use a Miller 1 straight blade laryngoscope for term babies, a Miller 0 for premature babies, and a Miller 00 for extremely premature babies. Use a 3.5 uncuffed tube for term babies, a 3.0 for premature babies. In terms of depth of insertion, there are reference charts in terms of gestational age, but you can also measure the middle of the lip to the tragus of the ear and add 1 centimeter. If you're struggling to intubate, go back to bagging until you can safely place a laryngeal mask airway. Size 1 LMA fits all. Remember that the vast majority of cardiac arrest in children is due to a primary respiratory problem. You are not looking at that O2 sat. Remember, it is just slowly coming up as the peripheral circulation also matches the central. It's not that accurate in the first 10 minutes of life. You are looking at the heart rate first and foremost and the work of breathing. If your work of breathing is not adequate, that's okay, we can help you. But if your heart rate starts to slow, that is desperation time. The neonate's metabolism and oxygen consumption is so high that the heart is ultra sensitive to hypoxia. Also, Starling's forces do not really apply to an immature heart. The only way a child can improve his cardiac output is through an increase in heart rate. If you've lost that defense with signs of overt bradycardia, that child will arrest any second. What's the trigger rate for positive pressure ventilation? Less than 100 beats per minute. Gotta get those O's in. What's the target rate for compressions? Less than 60 beats per minute. Just do it. I know we wait until adults get pulseless, but not so here. Less than 60, compressions. We mentioned a bit about the options for chest compressions in newborns and young infants. If you're by yourself for the first few seconds to minutes of a code in an infant, then you'll want to do the 2-fingered compressions at the sternum. Most of the time, however, you'll have at least one set of hands on deck. One person to deliver rescue breaths via self-inflating bag or anesthesia bag, and one to do compressions. In this case, the 2-thumb encircling technique is recommended. Encircle the infant's chest with both hands, spread your fingers around the thorax, and place your thumbs together over the lower third of the sternum. Forcefully compress the sternum with your thumbs. The 2-thumb encircling hands technique produces higher coronary artery perfusion pressures. It delivers a more consistent depth and force of compression as well. This may lead to higher systolic and diastolic pressures. At this point, we're ready to talk drugs. Epinephrine 0.02 milligrams per kilogram per dose, which is higher than the usual PALS dose of 0.01 mg per kg every 3 to 5 minutes. Okay, here is another huge difference between NRP and PALS and ACLS. In PALS and ACLS, there's an appropriate emphasis on minimizing pauses and compressions. We know in animal models that coronary perfusion pressure drops substantially during a pause in CPR and takes some time to reach peak perfusion levels again, only to be interrupted immediately afterwards. In adults and children, minimal interruptions to CPR is the standard. Now, in comes the neonatal disruptor. The NRP, on the contrary, recommends synchronized chest compressions and rescue breaths at a ratio of 3-1. So that's compression, 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 ventilation. 1, 2, breathe, 1, 2, breathe. The emphasis here is on a well-delivered rescue breath. Whether you are bagging or you've already placed an LMA or an ET tube, you're going to pause to give each rescue breath. This runs totally counter to everything you know about every other situation. The emphasis on NRP is getting the child to make that first breath, to oxygenate, to ventilate. Trying to deliver a rescue breath through a compression with a very compliant thorax will not deliver the amount of air with an adequate pressure needed. So regardless of how you deliver the breath, it's 120 events per minute with a 3-1 compression to ventilation ratio. Compression, 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 pause to breathe, compression, 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 pause to breathe, compression, 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 pause to breathe. Give that kid a break to breathe. 120 events per minute, meaning if you have compression 1, 2, and 3, and then breathe, and then 1, 2, and 3 compression, and then breathe, you'll likely get close to 90 compressions and 30 ventilations per minute. I'd like to make a point of clarification. Often I'm asked, when do you go from NRP to PALS? NRP was designed specifically for babies upon delivery. And so all that we've talked about for sure should be used in the delivery room, of course, but sometimes mommies just don't make it upstairs and we deliver babies not infrequently in the parking lot, in the waiting room, in the emergency department. The Neonatal Resuscitation program is tailored to the needs of the newly born. The emphasis is on precipitating normal transition by taking that first good breath, which starts the cascade of cardiopulmonary changes from a placental circulation to a pulmonary circulation. During fetal development, the baby's lungs are full of liquids secreted by the epithelium of the alveoli. In fact, the glottis is kept adducted to allow for more fluid accumulation within the lungs so that the prenatal lung volume is actually much higher than the resting lung volume after birth. This is essential in the proper development of the very compliant lung tissues. Uterine contractions during labor will clear out a substantial volume of fluid from the lungs before birth. Then the stress of labor causes a release of fetal adrenaline to stimulate epithelial cells from secreting to absorbing it. So there's that transition there just from the epinephrine, the adrenaline from the fetus itself. Now, the main event, birth. The alveoli at birth are still filled with some fluid. The first time a baby breathes in, an active pressure gradient shifts fluid into the pulmonary interstitial tissue where it is gradually siphoned off via the lymphatic and pulmonary circuits. In term babies, this is where surfactant is especially helpful. It breaks the surface tension of the liquid and allows the opening pressures of each alveolus to drop, making it much easier to pop open and facilitate gas exchange. The chest expands, creating a subatmospheric intrathoracic pressure. It's one thing to bring air into the airway, but the magic of surfactant keeps those alveoli popped open and available for gas exchange. The first breath may not happen up to 30 seconds after birth. Even then, the newly born will keep the glottis closed to help trap air, keeping an initial positive intrathoracic pressure of about 35 millimeters of water. This breath, then a hold, is physiologic and really essential for that first cascade of liquid clearance in the lungs. So in practice, you'll see a little pink to purplish babe take a moment to cry, and then you won't hear that much for just a moment. But the baby happens to be improving, and then you see some consistent crying, and that is all okay. As we mentioned, our clinical assessment is the most important here. Warm, dry, stimulate, and cry. We are good. The SpO2 will be inaccurate. What is it going to be at 60 seconds? It's going to be 60% at 60 seconds. Watch that wristwatch, and for every minute, we go up by 5%. All right, just checking in with you. It's normal at first to have irregular respirations, but we have to make sure to distinguish that from apnea or gasping. It's normal to have deep, rapid inspiration, then prolonged expiration. Over the next several hours to days, there are gradual changes in lung compliance and chest wall compliance and ongoing microcirculatory adjustments as the baby continues to transition to a whole new way of getting and staying oxygenated and ventilated. All of that said, NRP is mainly for the main event, for birth. But the more we talk about physiology, the newly born baby's slow transition, his delicate lungs, his sensitivity to hypoxia, his lack of thermal regulation, the more that you can see some of these concepts come in handy when the baby comes back to the ED in a day or two, or in a week, or 2 weeks, or up to a month. So, in short, if the 1-week-old or 3-week-old needs resuscitation, of course, PALS will be your friend. But like we tailor care to each patient, knowing the techniques of NRP and the special needs of the newly born will just make your PALS care more informed and likely more effective. In summary, only 10% of newborns need some assistance to get them to take that first breath, and only 1% need you to intervene aggressively. Mother Nature loves us and wants us to breathe and be happy. But even she gets tired sometimes. She needs some help about 1% of the time. You have 30 seconds to dry, stimulate, and suction if needed, and up to a minute to start positive pressure ventilation if needed. For apnea, gasping breaths, or a heart rate of less than 100, you start positive pressure ventilation. Mr. SOPA can help you troubleshoot, mask, seal, reposition, suction, open the mouth, increase pressure delivered, and finally advanced airway as needed. If the heart rate drops below 60, start CPR, and remember, 2 thumbs encircling is best. Allow for full recoil, and you give synchronized compressions and ventilations 3-to-1. Compression, 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 pause for the breath, compression, 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 pause for the breath. Keep going, make sure you have a cardiac monitor on if it's not on there already, and get ready for an advanced airway. The baby's heart rate is still less than 60. You need epinephrine. Double the PALS dose to 0.02 mg per kg per dose. It's usually better through the umbilical vein or through an IO if you have an IV, hallelujah. But keep trying to find whatever you can that can be reversed. Teamwork and be methodical. Voice what you're doing to help keep yourself on track and let others into where you are. And until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.